Welcome to AETCM, the emergency medicine channel.
Yes.
A 62-year-old male was brought to our ER with complaints of headache and confusion. On initial 10-second assessment, airway was patent, there was no pooling of secretion, breathing, air entry bilaterally equal with a respiratory rate of 16 breaths per minute with a saturation of 97% on room air. Circulation-wise, BP was 130/90 with a pulse rate of 62 per minute. Disability-wise, GCS was E4, V4, M6. Pupils bilaterally equally reactive. Exposure-wise, temperature was 98 degree Fahrenheit with a GRPS of 87 milligram per deciliter. Coming to adjuncts to primary survey.
So, what are the primary problems here? Saturation is low, pulse is low.
Pulse is low, saturation is 97, sir.
90.
Respiratory rate is 16.
60.
16.
Pulse is low.
Pulse is low and confused.
Glucose
Patient is confused. Sugars is on the lower side. Patient is confused also. Coming to adjuncts to primary survey, patient initially we had taken one VBG to rule out any electrolyte abnormality. VBG showed no acid-base abnormality. There was no pH was normal 7.4 with the PCO2 of 38 with the bicarb of 21, but it showed sodium of 116.
116.
So suspecting initially we thought it could be hyponatremia induced. Patient coming to history of the patient. Patient is a 62-year-old male. He presented to ER with complaints of headache along with 2 episodes of vomiting since the previous day. He had history of shivering with mild slurring of speech and agitation since that day morning. So he was initially taken to a local hospital where they mentioned slurring of speech with altered sensorium and right-sided facial deviation. So when they went ahead with taking one MRI brain stroke protocol, which didn't show any acute infarct. For further management, patient was referred to our center. Patient did not have any history of any fever, cough, breathlessness, any trauma or any fever or any abdominal pain, dysuria, no history as such. On arrival to our ER, initially one CT brain plane was taken from emergency itself to rule out any IC bleed, but it was not there, it was normal. So we had admitted the patient and we had sent all routine workup including hyponatremia workup for the patient.
What are the 3 main investigations you do in hyponatremia?
We have to send the serum osmolarity, urine osmolarity and urine sodium. When the labs came back, patient's thyroid function test was very altered. TSH came more than 100. With that, patient's sodium workup wise, patient had a urine sodium of 147 with a urine osmolarity of 509 and serum osmolarity of 249.
What is SIADH? Can you tell the definition of SIADH?
Sir, SIADH is syndrome of inappropriate ADH secretion. It has a few criteria to fulfill. Their urine sodium should be more than 40. Your serum osmolarity should be hypoosmolar, less than 280, and urine osmol should be more than 100. And with that, conditions like hypothyroidism, hypoglycemia, and hypocortisolism should be excluded.
So, if you have a patient who is having suspected SIADH, you have to do minimum 3 investigations. In that, one of the investigation is positive here. So, SIADH is ruled out.
Yes.
It is all because of the hypothyroidism.
We then attributed this confusion. Patient was having bradycardia. Patient's sugars were on the lower side. With that, patient was confused with a TSH of more than 100 and sodium of 116. So, attributing is to hypothyroid-induced hyponatremia. We started the patient on correction of Thyronome. 300 mg Thyronome stat was given to the patient.
T3.
T4.
Thyronome is T3.
Thyronome T3, triiodothyronine was given 300 mcg. Actually, in this scenario, we should go ahead with IV correction, but since it is not available, we went ahead with oral correction for the patient. At the same time, we had started the patient on 3% sodium correction also, since sodium was low and patient was in altered sensorium. With that, we continued the same treatment for 1.5 days, but since patient's sensorium was not improving, we went ahead and his CRP started rising up. Initially it was 5, then went up to 33. So we went ahead with the lumbar puncture. But the lumbar puncture showed only 1 cell and there were no significant findings, so meningitis was ruled out. By the 3rd day, patient's sensorium improved. He started taking feed orally. His sodium improved, his TSH from a dose of 300 we started reducing since his heart rate started improving. It was initially in the 60s
So
range.
suppose you give 600 microgram in first day or 1000 microgram in first day, what would happen to the patient? Why we are not overcorrecting? We can correct it in one day itself, no?
Heart rate will jump.
Heart rate will jump and
Heart failure.
heart failure.
Heart
They
failure.
go to failure. If you overtreat the patient in acute phases, like even if it is hypothyroidism and myxedema, if you give more tablet, then suddenly it can reverse and patient develops tachycardia and cardiac failure. And some patients can go to coronary artery disease also because already existing problem will be there. So that's why graded increase in is ideal. Since we don't have IV this one, we are giving only oral. So that has got its own disadvantages. Absorption will be delayed, absorption will be less comparing with IV. That all are there, but this patient has improved.
So we, according to the heart rate, we slowly tapered the dose, and we had discharged him with at 125 microgram per day, and asked him to review later with.
What was the ECG change? Have you noticed any change?
ECG changes. Patient ECG showed sinus bradycardia only. There were no small low voltage complexes, as should we suspect in case of a hypothyroidism, because patient might have pericardial
low voltage
effusion.
complex with bradycardia is the most important thing. Here only bradycardia
was there.
What other findings are common in ECG in myxedema coma other than this? These are the common things. Other than that, any other waves which is Osborne waves.
Hypothermia.
Osborne wave is a very common finding, but it is not diagnostic of hypothyroidism. It's a diagnostic feature of hypothermia.
Our patient did not develop hypothermia as such. Coming to hypothyroidism, basically hypothyroidism will be diagnosed with high serum TSH with a low serum T4 and low serum T3. How we initiate patient on maintenance doses of thyroid correction is basically 1.6 microgram per kg body weight per day, and the range can be 50 to 200 microgram per day. And if in case of young age, we will start on the full dose. In case of old age, we will initially start with 25 to 50 microgram, and then repeat the TSH in 4 to 6 weeks. And then according to the value of the TSH, we can either increase by 12 to 25 microgram per day or decrease by 12 to 25 micrograms.
So no need to start the full dose in first day.
Initially.
And you can wait. Slowly only we should increase. Even in acute phase also we should increase very slowly. Otherwise patient will go to cardiac failure.
Then coming to myxedema coma, severe hypothyroidism leading to decreased mental status or altered sensorium with hypothermia, hypoglycemia, hyponatremia. These are the features of myxedema coma. It is a medical emergency. It is usually the hallmarks will be decreased mental status, hypothermia with hypotension, bradycardia, hyponatremia, hypoglycemia, and hypoventilation can occur.
Okay. So here respiratory rate is low.
Low. But
Okay.
patient
So that
did
is
not
a
develop
clue.
PCO2.
Okay.
Patient did not develop any PCO2 buildup in our case. There will be puffiness of the hands, face. There will be a thickening of the skin, and there can be enlarged
What are the
tongue.
cause for central sleep apneas? Central sleep apnea syndrome.
Short neck, obesity.
Central. There are peripheral and central.
Myxedema.
One of the thing is hypothyroidism.
Hypothyroidism.
There are a lot of reasons because the peripheral means the apparatus is defective and some obstruction is. Central means some suppressive problem in the brain. One of the condition is hypothyroidism.
Also, secondary to sometimes macroglossia, they can have enlarged tongue. They can have due to secondary to non-pitting edema. So these patients are prone to develop PCO2 buildup when they sleep. Then coming to neurologic manifestations, patients might be in coma, but mostly will be in altered sensorium, confusion, obtundation, and sometimes patient might be agitated. That is what we call as myxedema madness. Patient sometimes might develop seizures, mostly due to hyponatremia. Then coming to hyponatremia, in myxedema, the reason for hyponatremia is due to excess secretion of vasopressin, that is our ADH, due to which water retention occurs and patient goes into dilutional hyponatremia. With that, hypothermia due to loss of thermogenesis, because thyroid hormone is dysregulation is there, due to patient might go into hypothermia. Decreased metabolism is there. Hypoventilation with respiratory acidosis due to central depression of ventilatory drive with decreased responsiveness to hypoxia as well as hypercapnia. With that, there can be respiratory muscle weakness and mechanical obstruction by large tongue and sleep apnea. Then hypoglycemia in patients with concurrent adrenal deficiency it could be due, it could lead to hypothyroidism can lead to hypoglycemia in case of concurrent adrenal deficiency.
Adrenal deficiency will produce hypotension.
With the
So that can also associated with sometimes this type of case. You can have hypoglycemia. You can have hypotension also. So in hypotension, the treatment is slightly different. You have to add steroid.
Steroids we have to give. And then in cardiovascular system, patient will have bradycardia, patient will have decreased cardiac output, narrow pulse pressure.
Is it diastolic dysfunction?
Diastolic hypertension will be
there. Diastolic
dysfunction. Diastolic dysfunction will be there. And then decreased myocardial contractility, sometimes hypotension. Then pericardial effusion, low voltage ECG can be there, and large cardiac silhouette can be there on chest X-ray. Then to diagnose, we usually have to send the thyroid profile. We have to send the TSH, T4. We should also send for the cortisol levels to know if there is concurrent adrenal deficiency. Till adrenal deficiency is ruled out, we can start on steroid supplementation for the patient. Treatment wise, we have to give levothyroxine T4, that is 200 to 400 micrograms IV, followed by daily doses of 50 to 100 micrograms. And if T3 we are giving, that is 5 to 20 mcg, followed by 2.5 to 10 mcg every 8 hours. Then after IV, we can change to appropriate oral doses once the patient starts tolerating. That we have to divide the IV dose divided by 0.75. Then we have to give IV hydrocortisone every 8th hourly till we rule out adrenal insufficiency.
So what is the, you are told hydrocortisone TID. What is the difference between replacement dose of steroid and anti-inflammatory dose of steroids?
Replacement doses are 50 mg every 6th hourly.
So replacement dose is multiple doses. Every 6th hourly you have to give 50 mg, or you can give it as infusion. But anti-inflammatory, whatever dose you want to give, it has to be given at once and preferably in the morning time. Okay.
Then other supportive measures, if patient has hypotension, one will start with fluids, we'll start with hormone replacement. If not, sometimes inotropes might be required till TSH
What inotrope will be ideal for this patient? What all inotropes will be ideal? Any patient with hypotension, you start noradrenaline. Second line of drug?
I can start dopamine because heart
they
rate.
have severe bradycardia. So dopamine will be an ideal choice.
Then in case of hypothermia, we have to manage hypothermia. Rewarming has to be done. In case of patient coming in coma, patient is severe respiratory acidosis, patient might require mechanical ventilation till her sensorium improves. Till then IV thyroxine has to be given. And glucocorticoids, still central hypothyroidism is ruled out.
What is this central hypothyroidism and peripheral hypothyroidism?
Central hypothyroidism will be due to suppression of the hypothalamic pituitary axis. There will be deficiency. There will be deficiency of thyroid releasing hormone.
Okay, so there will be deficiency of multiple multiple hormones. Okay, there you get all type of hormone deficiency with hypothyroidism. Whereas in peripheral hypothyroidism, that is primary. Primary, you have only hypothyroidism. It is not associated with other features. Like hypertension is not very common, but sometimes infections can trigger myxedema. In that infection, because of infection, patient can have adrenal deficiency and patient can also have myxedema. In that case, you can get both the things.
And then when to suspect hypothyroidism, clinical feature wise, patient will usually have fatigue, low speech, there will be cold intolerance, patient might be complaining of constipation, weight gain will be there. On examination, we will have the hung up reflex, that will be the delayed relaxation of the deep tendon reflexes. Then patient will have bradycardia. Then accumulation of glycosaminoglycans in interstitial spaces, so it will be having non-pitting edema. Then coarse hair, puffy face, then enlarged tongue, hoarseness of voice might be there. Skin will be cool, pale with that hair.
Cool, thick.
Cool, thick. Cool, thick will be there. Then patient eyes, periorbital edema can be there. Sometimes after Graves disease treatment, patient might go into hypothyroidism. Then that can be anemia, normocytic normochromic anemia can be there. With that, in CVS, low cardiac output, hypotension. Cholesterol will increase, sir. In hypercholesterolemia will be there. Hyperhomocystinemia will be there. In respiratory system, sleep apnea, macroglossia, hypoventilation will be there. Patients sometimes require CPAP at night. In reproductive system in females, there can be oligomenorrhea or hypermenorrhea. Both can be there. And most commonly, metabolic abnormality, hyponatremia and hypoglycemia can be seen.
Hypo or
Hypoglycemia.
hyper? See, in acute condition, it is
Myxedema,
hypoglycemia. But in chronic hypothyroidism cases, many are associated with hyperglycemia, diabetic, thyroid diabetes. They can have immune-mediated diabetes, immune-mediated hypothyroidism. So that is a very common combination. What is subclinical hypothyroidism?
And where TSH will be normal, T4 will be high, but T4 will be normal.
TSH will be slightly higher,
T4
mildly
will be
higher.
normal.
There will not be any clinical findings. Okay. So there are a lot of patients you can see like that when you are practicing. When will you start thyroid hormone in that type of cases?
Subclinical, in case of symptomatic only,
In
we will
case
start.
where the patient becomes symptomatic, you can start. Otherwise,
Otherwise,
if the cholesterol is very high, family history is there, enlarged thyroid gland
is there.
dyslipidemia, pregnancy. In that, pregnancy is the most important thing. Okay, because if you don't start in pregnancy, the child will have problem. Okay. What is TPO?
Peroxide oxidase,
Thyroglobulin.
peroxide.
Okay, it's an antibody against
autoimmune
thyroid. Okay, in subclinical hypothyroidism, if TPO is positive,
we have to
definitely you have to start because this patient is ultimately is going to eventually he'll develop hypothyroidism after a few months or years. So you have to start treatment. If you don't treat, what will happen? Subclinical hypothyroidism with all these things, you don't treat, what will happen? Which is the most important organ affected in chronic subclinical hypothyroidism? Heart. Your memory will lose. Brain will be affected. Like subclinical hyperthyroidism is a thyroid T3 T4 is slightly higher. There is no clinical finding. In that case, patient develop osteoporosis. Bone is affected there. Hyperthyroidism, bone is affected. Hypothyroidism, brain is mainly affected. So chronic hypothyroidism, even if it is subclinical, if it is not treated, slowly these patients may develop dementia. Okay. Whereas other one will produce bone osteoporosis. So that also we should keep in mind. Any patient who is having subclinical, better to start small dose. Okay. What is secure thyroidism?
Secure thyroidism, sir, both serum TSH, T3, T4 will be mildly elevated in case of infections. But if you repeat it after infection, everything will come normal.
So there will be an unusual pattern of elevation of one or other test, but there will not be any clinical finding correlating with your this one. Once the sickness is over, the thyroid function test will be also become normal. So that's why whenever you are suspecting, you do thyroid function test. If you don't have any suspicion, unnecessarily do thyroid function in ICU may be dangerous. So you make some mistake and you can make wrong diagnosis and you will start treating for that patient. So better not to do thyroid function test unless until you have a strong clinical suspicion. Okay. Anything else? Nothing. Okay. Thank you.
Thank you.